Thank you very much for this kind invitation. It's definitely a pleasure to visit this beautiful city and this great congress. My task has been to talk about the evidence against the use of mesh in patients postpartum. I just want to see if this works. I have these disclosures, but I don't think they're relevant because my obligation today is to talk against the use of mesh from these two companies. There's a small mistake in this slide here. It should say that 16% of all patients operated for ventral hernia are women of childbearing potential. Not 16% of all women develop these hernias, but they make up to about 16% of the total population being operated for ventral hernia. And so far, there is no consensus on the management of these patients. There are several concerns when we sit like surgeons and have to decide for treatment of these patients here. Do we use a mesh? And that's the task of the presentation here to look into. Do we operate by open means or by laparoscopy? What about hernia repair before any kind of pregnancy? And will it remain intact when the patient becomes pregnant after the repair? Is there any problems in terms of pain during pregnancy? And is there any period to go through before you repair a hernia after a pregnancy? Moreover, is it risky to leave a patient with a hernia and treat her after the pregnancy? Are there any problems during the pregnancy in terms of pain or incarceration and so on? The current case, as I understood it, deals with a patient who had an asymptomatic hernia during her pregnancy. And 6 months after delivery, we had a patient with symptoms in terms of pain, and the hernia was described as a 4-centimeter defect. And it's a primary ventral hernia, probably an umbilical hernia. And we repair the hernia, but the patient plans a new pregnancy 4, 5, 6 years later on. So the question here is, do we have to use a mesh or not a mesh in this situation here, where she's not pregnant at the moment? There is very, very little evidence out there. I think there are only 3 trials, 3 studies that are relevant when we have to address this problem. 2 of them are from my own institution by my colleague Erling Oma, Christian Kim Jensen, and myself. And I will shortly take you through these 3 trials. They are all based on registry data. You need large numbers to look into this. The first study we performed was in 2017, looking at patients undergoing ventral hernia repair, more than 3,000 patients. 267 of these women became pregnant afterwards, and we found that pregnancy was associated with an increased risk of recurrence. This is a little complicated. We identified these patients because all hernia repairs are to be registered prospectively in Denmark into the Danish hernia database. After that, we used the social security number of the patient to follow them, and we obtain 100% follow-up this way. And we combined these data with data from the Danish Medical Birth Registry, finding that 287 of these patients became pregnant afterwards. Then we looked into, again, the Danish hernia database and also the Danish National Patient Registry, again using the social security number of the patient, so that we captured all patients with a description of a new hernia or a reoperation for the same hernia, and found that 34 developed a recurrence among those who became subsequent pregnant. And what were the risk factors for development of recurrence? I've shown them here. you see that a subsequent pregnancy was an independent risk factor for a hernia recurrence. So the same was for increasing size of hernias. Moreover, we found that umbilical and especially incisional hernias elevated the risk of recurrence as compared with an epigastric hernia. And this plot demonstrates the differences if you deal with umbilical or incisional hernias, where the lowest risk was found for epigastric hernias. The next study is an American study. It's a bigger study than ours. I think it comes from Cleveland, Ohio. These were mainly incisional hernia repairs. There were also some primary ventral hernia repairs. A population of 840 patients becoming pregnant subsequently. And again, in this study, by multifactorial analysis, it was shown that a subsequent pregnancy elevated the risk of recurrence independently from some of the other risk factors we know from other studies: wound complication, diabetes, obesity, and tobacco smoking. A very interesting study, I think. Our last study from our own institution was a population where we looked at an exposure, whether the hernia was performed by the use of mesh or just by suture repair. And surprisingly, we found that the mesh repair did not protect the patient for a recurrent hernia when she became pregnant afterwards. The trend was actually completely the opposite. Here is the design of the study. A lot of patients with repair before the pregnancy. And here is the plot. And we didn't find a significant difference there, but as I mentioned before, mesh repair tended to increase the risk of recurrence. Why is this so? There might be some kind of issue with the mesh placement, mesh fixation in the subsequent expanding abdominal wall of a pregnant woman. So this is very interesting, and I think this talks against the use of mesh in a patient who will become pregnant afterwards. I want to draw the attention to the fact that there are studies out there reporting on pain from the mesh side in pregnant females. So that's also a detail to look into, I think. But the studies are very few on this subject. So the summary, Chairman, ladies and gentlemen, will be that subsequent pregnancy elevates the risk of recurrence. We don't find the effectiveness from the use of mesh in this specific indication in patients becoming pregnant after the repair of a ventral hernia, a primary ventral hernia. There is a problem with a pain issue in these kind of patients, which we have to inform the patients on. And definitely we need much more research. So the recommendations for your patients should be that, if possible, postpone the repair until she has had the last pregnancy. If it's a symptomatic hernia, like it was described in this case here, I would argue for the use of suture repair because of the problems with pain and the lack of effectiveness from this single trial we had from Denmark. And just one final note, please mark this in your calendar. That will be the next International Hernia Congress 3 years from now, after the one that was recently held successfully in Miami, Florida. Thank you very much.